Thank you for that introduction, and thank you to SAGES for the privilege of being able to present our work today. These are our disclosures, and they are relevant to today's talk. As you know, magnetic sphincter augmentation is a dynamic device that's used to control chronic reflux disease. It improves the quality of life in GERD patients at about 83% of the time. It allows them to be free from PPIs about 75% of the time, and it does maintain their ability to belch and vomit, and is thought to have a reoperative rate around 5 to 7%. And this has been shown in multiple studies over the last several years. However, some patients do not experience the expected outcomes that we had when we place a magnetic sphincter. We know from previous work that a structurally defective sphincter might have something to do with impacting outcome in terms of length, abdominal length, and LES basal pressure, such that a sphincter preoperatively that has one defect in it will only be normalized about 77% of the time. And if you had two defects in terms of length, abdominal length, or pressure, that you could only normalize that sphincter in about 56% of the time. And that in patients who had a persistently defective lower esophageal sphincter, they led to a higher PPI use. We also learned in that analysis that a higher BMI patient had worse postoperative LES dysfunction, and as such also was on PPIs. Lastly, hiatal closure may have some impact on the ability to restore lower esophageal sphincter competency. The objective of this study was to determine the factors leading to an excellent to good outcome with a magnetic sphincter augmentation device based on using preoperative and operative factors. We combined two databases. Our prospectively collected LINX patients in the Swedish esophageal database, and we acquired the de-identified data from the pivotal trial that Thorax Medical used to produce their New England Journal paper and their 5-year paper in clinical gastro and hepatology. And we excluded patients who did not have follow-up of a year, and we ended up with 170 patients to use in this analysis. We used univariable and multivariable regression. We selected preoperative and operative variables for that regression analysis, and we used it to predict what we thought was a good and excellent outcome. These are the data elements we used. We selected a number of patient characteristics, both demographic and symptom-related, along with PPI use. We chose endoscopic features that surgeons would find at the time of surgery preoperatively, and then we used operative factors to include there, and we use objective testing, both high-resolution manometrics as well as pH data obtained from the impedance or a Bravo score. We defined a priori outcomes, excellent, good, fair, and poor, and we based it on a grouping of GERD-H-Correll scores, whether or not the patient was taking PPIs or not, or using them daily, and whether they had esophagitis or not on postoperative endoscopy, and whether that was graded as A, B, C, or D based on the LA classification. At baseline, there were 170 patients who had a median age of about 53. They were evenly split between men and women. The average BMI was 27, and we had a range of BMI categories. People had mostly typical symptoms, and most patients had a relief to PPI on some level. At baseline, the preoperative LES had relatively normal lengths, normal intra-abdominal length, but low basal pressures. When we categorized them into whether they were structurally defective or not, only 50% of these patients had a normal sphincter, meaning that length, abdominal length, and pressure were all within the normal range. About a quarter of patients had one of those defects, and another quarter had at least two defects, and a minority had all three deficient in their evaluation. While it was most common to have no hernia, when you look at all hernias, the majority of people had a small hernia going into this analysis, and only 39% of them had their hiatus closed at the time of LINX implantation. Pre- and post-acid scores show that the Demeester score improved significantly, as did the percent time pH less than 4, the percent time when it was upright, and the percent time supine, all had dramatic improvements after magnetic sphincter augmentation placement. When we came to our A priority outcome categories, we put people into each of these categories, and we ended up with an excellent outcome in 47% of the patients, a good outcome in 28% of patients, only a fair outcome in 22% of patients, and a minority of patients had a poor outcome at 3%. In univariable analysis, BMI, Hill grade 2, 3, and 4, and a residual LES pressure that was elevated all were significant variables leading to a negative impact on excellent to good outcomes. We used these three for our multivariable analysis, and we included hiatal closure and the structurally defective sphincter based on our previous analysis to be part of our multivariable model. That multivariable model showed that BMI, particularly those greater than 35, a preoperatively structurally defective lower esophageal sphincter, and residual LES pressure remain significant negative impacts on achieving a good to excellent outcome, whereas hiatal closure and the Hill grade did not seem to have as much an effect, though the Hill grade 2 trended towards significance. We took that to mean that a higher BMI patient, particularly those over 35, really should be counseled potentially about alternative options rather than magnetic sphincter augmentation. The presence of a structurally defective sphincter suggests that this is a more advanced population of GERD patients, and perhaps there's a need for a more formal hiatal hernia repair prior to LINX implantation, or perhaps those patients should be pushed towards Nissen fundoplication to achieve a better outcome. We were unclear, and we still aren't certain what the role of the residual LES pressure may play on negatively affecting the outcome of these patients. The Hill grade 2, while not significantly associated in the multivariable analysis, may give us some clues around what to do at the time of surgery, such that it's very simple for a surgeon to understand what a Hill grade 4 valve looks like at the time of laparoscopy. Those patients get repaired and the LINX gets placed. A Hill grade 1 valve, similarly, will look very normal, and we probably won't close the hiatus, simply put a LINX in. Hill grade 3, more like a 4, will get repaired, but a Hill grade 2 valve probably is underestimated in terms of hiatal laxity, whether or not there is a small herniation there, and perhaps more formal repair might be required for these groups. There are some limitations to this study. There's pooled data from two prospectively collected databases, and we don't have the ability to control what went into the pivotal data. We did not include patients who had a hiatal hernia greater than 5 centimeters, Barrett's esophagus longer than 2 centimeters, and LA class C and D esophagitis were not part of this patient population. All the centers that put data into these databases were high-volume esophageal centers, and they were early adopters of LINX. In conclusion, the majority of patients experience good to excellent outcomes when having a magnetic sphincter placed. Preoperative factors which negatively impact our ability to achieve an excellent or good outcome were a rising BMI, particularly that over 35, the presence of a structurally defective sphincter, and elevated residual pressure. And surgeons implanting magnetic sphincters should consider these as part of these preoperative factors as part of patient evaluation, selection of patients for magnetic sphincter implantation, and things to consider at the time of operation. Thank you.